Welcome. I'm Michelle Kauf, Executive Director of Business Development at Rogers Behavioral Health, and I am your moderator for today's webinar on adapting parent-child interaction therapy for anxiety treatment. Joining me today are Dr. Sim-Yen Tan, Clinical Supervisor at Rogers Tampa location, Dr. Shanee Toledano, Clinical Director of our Atlanta location, and Dr. Mina Yadegar, Clinical Supervisor at Rogers Los Angeles location. Before we get started, I want to do a quick overview of the format. The webinar is scheduled for 90 minutes. There is no need to check in. To receive CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and a list of references will be available after the program via an email sent from ce-go.com. In addition, a recording of the webinar will be published on the resources section of our website within the next few days for you to rewatch. Our speakers will give a 75-minute presentation. Following their presentation, I will facilitate the Q&A session. If you would like to ask our speakers a question during the presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you simply click on the Q&A button on the Zoom taskbar. I will review the questions submitted, then the presenters will address them during the Q&A portion of the webinar. Now I'll turn it over to our presenters.
Thank you, Michelle. Hello, everyone. Thank you all for being here today. Before we get started, I'd like to note that Drs. Toledano, Yadegar, and I do not have any financial related disclosures to report. Next, I'll go over the learning objectives for this webinar. So upon completion of this instructional program, participants should be able to describe the standard PCIT components and at least 2 differences and 2 similarities with adaptations for anxiety. And 2, list 2 ways PCIT parenting skills can be applied to exposure-based treatment for anxiety. And here's a list of topics that we will be covering in this webinar. We'll start with an overview of PCIT, and then we'll move on to talk about PCIT adaptations for anxiety, and then applying and integrating PCIT components. And lastly, we'll close with the moderated Q&A. So I'll start with an overview of standard PCIT. So PCIT stands for Parent-Child Interaction Therapy, and it is a treatment that has been developed in the 1970s by Dr. Sheila Iberg at the University of Florida. It is an evidence-based treatment that incorporates play as well as behavioral parenting training principles, and it's also based on attachment as well as social learning theories. And when it was first developed, PCIT targeted young children ages 2 to 7 with behavioral problems commonly associated with the diagnosis of oppositional defiant disorder, ADHD, as well as conduct disorder. So here are some of the defining features of PCIT. So PCIT involves both the parent and child together in treatment. So treatment is conducted through live coaching sessions where parents and their child are in a playroom while the therapist is in an observation room watching the interaction through a one-way mirror or sometimes a live video feed. And the parents and the therapist typically would wear a bug-in-the-ear device, which allows the therapist to provide in-the-moment life coaching on parenting skills to help the parent manage the child's behavior. PCIT has also been conducted where parents and therapists are within the same room. And most recently, we have seen an increase in the implementation via telehealth, also known as Internet PCIT or iPCIT. PCIT is also a treatment that's very assessment-driven, which I'll talk about it in a little bit. And the progression in treatment is contingent upon meeting certain expected competency criteria, which I'll discuss shortly as well. So here's an overview of the treatment components. There are 2 treatment phases that include the live coaching of parent interactions with their child, as well as ongoing assessments that include the use of standardized instruments and behavioral coding of parent-child interactions. So the 2 treatment phases of PCIT include the first one, child-directed interaction, also known as CDI. So CDI focuses on the development of play skills through coaching of warm and accepting parent behaviors, as well as the use of differential attention. The second phase, known as the parent-directed interaction, or PDI, focuses on the continuation of CDI-related skills while coaching parents to use effective commands, as well as a timeout sequence for non-compliance behaviors. And once parents meet the skill competency for both CDI and PDI, the skills are then generalized to both home and public settings. So now I'm going to talk a little bit more about the CDI phase. So the fundamental principle of the CDI session is to follow the child's lead. So during a play session, parents are coached to engage in what we call do skills and to avoid what we call the don't skills. So I'm going to start with the do skills. So the do skills are also known as the PID skills, which is an acronym. So P stands for praise, specifically label praise. This is where we would coach parents to label praises for specific behaviors that they want to increase. So for example, instead of using unlabeled praises such as great job or good work, we want to make it more specific, like thank you for sharing your toys with me. I like how quietly you are sitting. And this helps the kid be able to point out what specific behaviors is being reinforced over time. And as we all know, praises can also help improve the child's self-esteem and in turn improve the parent and child relationship as well. And R stands for reflection. So this is where parents are coached to parrot back, repeat back, or paraphrasing what the child is saying. And this allows, again, the child to lead the play, and it helps to show that parents are listening and understanding what their child is saying. Not only that, it can also help improve the child's speech and language skills. And I is for imitate. So this is where parents are just coached to do whatever the child is doing. So it demonstrates approval. So if the child is drawing, we encourage parents to draw as well. If the child is building blocks, we'll encourage parents to do the same. It also provides a great opportunity to teach play skills such as sharing and taking turns. The next one is D for describe. So here parents are coached to describe appropriate behaviors that the child is doing. Again, it allows the child to lead. It shows that the parents are paying attention to what the child is doing. Not only that, it also teaches vocabulary, concepts, model speech, and also keeps the child's attention on the task. An example of behavioral description would be, I see that you are putting the blue block on top of the red block. I see that you're pushing the truck. So things like that will help the child sustain their interests as well as attention on what they're doing. And lastly, E stands for enthusiasm. So here's where we help parents make the play fun, add warmth and interaction using appropriate tone of voice and gestures as well, like a little pat on the back or a hug. And so those are the PID skills or the do skills. And we also teach parents to avoid the don't skills. So 3 of the don't skills are giving commands, asking questions, and criticizing, because all of this don't behaviors are actually taking the lead away from the child and sometimes might also signal disapproval. During a CDI playtime, we also encourage parents to ignore any minor inappropriate behaviors. And in an event where the child gets aggressive or disruptive, parents are coached to stop the play and we will resume it another time. So during CDI play, in order to reinforce the CDI skills, parents are assigned daily homework. So homework is 5 minutes of special playtime. And the 5 minutes is short enough not to be too consuming and long enough for parents to be able to practice the skills and build positive parent-child relationship. So some of the suggested toys for the CDI phase includes anything that's creative and constructional, such as Legos, Lincoln Logs, drawing, train set, play food, dolls, farm animals, things like that. And then toys to avoid are things that are rule-bound or activities that could lead to rough play or potentially aggression or the need for limit setting. So some things include cards, board games, toy guns, swords, or anything that could get messy, like finger paints. So in order to move from the first phase of treatment, which is CDI, to the second phase of treatment, PDI, parents will have to first demonstrate the expected competency in CDI skills. So the expected competency criteria include the demonstration of 10 behavioral descriptions, 10 label praises, and 10 reflections with less than 3 commands, questions, and criticisms that's observed within a 5-minute coding session. So therefore, the number of sessions in CDI can really vary depending on the parent's competency. So next, I'm going to show a video example to illustrate what CDI skills look like. And as you watch this video, see if you can catch the do and pride skills, especially the label praises, the behavioral descriptions, and reflections.
That's very smart of you to know that you can make a gear factory. Now you're putting the orange piece on. I'm gonna get some more gears out for you.
So each color that's in there, we put 4 of them for each one of these.
You want to put 4 of each color. So
Yep.
I got you 4 blues there.
Yeah.
And, oh, you got out the orange. I like how you're working so hard on this, and I like how you know your color so well.
Guys, watch. When I turn one, it turns all of them.
Yep, when you turn one, it turns all of them. You're making them all turn. All right, you have 4 reds. Thank you for showing me what you're playing with, and I really appreciate how you're sharing the toys with me.
Watch, see?
Yep, you're showing me how it works.
So
And now you're putting the red one on there. And now you're putting another red gear on there. And now you're putting a 3rd red gear on there. And now you're putting a 4th red gear on
See, it
there.
turns all of them.
You're showing me how they all turn. I really like how you're making gears. That is so cool how you're making that. I'm going to make one just like yours because it's so cool.
Thank you.
Thank you for being so polite with me. And I like how calm that you're staying while we're playing.
All right, so in this almost 2 minutes video, there's actually a total of 9 label praises, 8 behavioral descriptions, as well as 3 reflections. And while the parent in the video seems to demonstrate the skills pretty easily, it can be quite challenging for some parents, especially in the beginning of treatment. And this is where the therapist would come in and to provide that additional coaching to help parents meet the expected competency criteria. So next, we're going to move on to parent-directed interaction, or PDI, which is the second phase of PCIT. And the goal of this phase is to decrease any non-compliant behaviors that do not respond to the differential attention in the CDI phase. So parents are coached to basically give effective commands here. So effective commands are defined in a variety of ways. So 1, direct versus indirect. So instead of saying, can you please get me the truck? Parents are coached to say, please hand me the truck. So it's more direct. Second, commands are coached to be given in a positive manner. So instead of parents saying things like, stop yelling, they are coached to say, please use your quiet voice. Commands also are encouraged to be specific. so the child knows exactly what they need to do. So instead of saying things like, you need to calm down, parents can say, take a few deep breaths. We want to make sure that commands are also age appropriate in terms of language and the child's ability. And we want parents to be able to give commands using a calm tone of voice, so the commands are actually being heard. We also encourage parents to only give explanation before a command if explanations are necessary, just to help prevent what we call dawdling behaviors, where the child might procrastinate by asking the explanation back and forth in order to not comply with that specific command. We also encourage parents to use commands only when necessary, as there are behaviors that we can redirect using CDI skills instead of commands. Throughout the PDI process, parents also learn to follow through with a calm and predictable response to the child's behavior. And this includes a timeout sequence, which I'll walk you all through in the next couple of slides. Similarly to CDI and PDI, parents also are required to meet a specific expected competency criteria, and this include over 75% of commands with correct follow-through. And then over time, we'll work on generalizing the skills to other settings outside of play, like house rules and in public settings as well. So here's the PDI command as well as timeout sequence. So both parent and the child are taught the sequence via modeling and role play prior to starting PDI. So it starts with a command. So parents will give a command. For example, please hand me the blue truck. If the child complies, parents are reinforcing with a label praise. And it's important that when we give a label praise here, that we're reinforcing the act of listening and compliance. Sometimes parents might say things like, thank you for handing me the blue truck, which is a great label praise. However, we want to make sure that we're reinforcing the act of listening here. So in an event where a command is given and the child does not comply within 5 seconds, parents will then provide a warning. If you don't hand me the blue truck, you'll have to go to the timeout chair. And if the child complies, again, parent will follow up with a label praise. However, if the child doesn't comply, then parents will safely and gently direct the child to the timeout chair where they need to stay for 3 minutes in 5 quiet seconds. So after 3 minutes and 5 quiet seconds on the timeout chair, parents will then give the original command. Are you ready to hand me the blue truck? If the child complies, parents are encouraged to acknowledge with a simple fine and then follow with the second command. If there's no compliance, then the timeout chair sequence starts again. If the child complies with the second command, then parent will follow with a label praise, great job listening, and return to CDI play. We want to make sure that all parents are coached to go back to CDI play after a command, just so that a child is not constantly flooded with commands during PDI. So in an event where the child gets off the chair, parents will give a one-time warning, and this warning is only given one time throughout treatment. And it goes something like, you got off the chair before I said you could. If you get off again, you'll have to go to the timeout room. So if the child gets off the chair again, then we will implement the timeout room procedure, which is 1 minute and 5 quiet seconds. In situations where space allows, there might be a separate timeout room. If not, parent would have to kind of soup the toys and leave the room and make the room that they're in a timeout room. And after compliance with the timeout room, the child is then redirected back to the timeout chair and the sequence starts all over. So the use of timeout sequence typically evokes some controversy, despite PCIT being an evidence-based intervention. So I will briefly review a position statement to address this controversy. So this position statement is put out by the PCIT International Policy and Advocacy Task Force. So PCIT has been recognized by the National Child Traumatic Stress Network, as well as other agencies, as a trauma-informed intervention. And one thing to remember, that timeout is just one component of treatment after parents have focused on building a nurturing relationship with the child. The timeout sequence is predictable and consistent, not only for the child, but also the parent. And throughout the timeout process, the parent remain in place throughout the procedure, so the child is not left alone. And as I mentioned earlier, PDI phase is always followed by the return to CDI skills to continue the building of warmth and accepting play behavior. And what we have found following PCIT intervention is that kids who have experienced trauma symptoms, their symptoms actually decrease over time, and that parents are less likely to use physical punishment. And it shows the child that, even if they do misbehave, their parents are likely to be calm and be able to provide a predictable and consistent consequences and follow through. So next, we will review the assessment used in PCIT. So there's two main assessments. So one is called the Didactic Parent-Child Interaction Coding System, also known as DPICS 4th edition. So a full observation of the parent-child interaction is completed pre and post treatment, and also a 5-minute observation is completed throughout treatment. And the coding is microanalytic. So in the example earlier, it looks into the specific counts for the behaviors. So number of label praise, number of behavioral descriptions, and so on. And it requires training to ensure the accuracy as well as the reliability of coding. And the second assessment that we use is called the IBERG Child Behavior Inventory, or known as the ECBI. And it's a parent rating scale that is administered at the beginning of each treatment session. And I'll go through both of these in a little bit more detail in the next few slides. So the DPICS 4 coding categories include 8 parent categories. So neutral talk. Neutral talk could, an example would be if a child's building a tower and parents making a comment that is a tall tower, or parents making a comment about what they're doing, like I'm drawing a flower. So that would be considered neutral talk. Behavioral description that we talked about earlier, reflection, label praise, unlabeled praise, question, negative talk. Negative talk could be a form of criticism or correcting behavior. For example, a parent might say something like, you should color the sun orange instead of green. That would be considered negative talk. Direct command, as well as indirect command. And then there's 3 child categories. First one's compliance, second's non-compliance, and the third one is no opportunity to comply. Sometimes when parents give multiple commands back to back, it's difficult for the child to comply, so we would code that as no opportunity to comply. And the use of DPICS in PCIT is very helpful in several ways. First, it helps determine the coaching goals for each session. So if during the 5-minute coding observations, parents are noted to struggle with label praise, then that will be the focus of the coaching session for that day. It also helps the therapist to be able to give feedback to parents on their weekly progress. It also determines when CDI as well as PDI expectancy are met. So it helps determine the progression from one treatment phase to the other. And overall, it helps quantify the quality of the parent-child interaction. And next is the ECBI. It is a 36 self-rating, which includes 2 types of scores: the intensity, which is the frequency of problem behaviors, rated on a 7-point scale, never to always, and problem, that's a yes and no rating, where a parent would rate if they consider a specific behavior as problematic or not. And the EGB provides information about parents' expectation about their child's behavior in general. And it's helpful because we can see how different caregivers might rate their child's behavior. It also helps to monitor the stress level of the parents and helps the therapist monitor progress over time. So research examining the effectiveness of PCIT has found significant reductions in child disruptive behaviors, improvement in child compliance, improvement in positive parenting skills, improvement in parents' confidence in managing difficult behaviors, reduction in parenting stress, and these improvements have found to be maintained at 1 year and 2 year post-treatment follow-ups. And next, I'll briefly review PCIT's adaptations and applications to diverse population. So adaptation is defined as changes to the essential elements of PCIT to make the treatment more applicable to new populations or more feasible in a particular service delivery setting. We do this when we think that standard PCIT won't work as well unless we make some changes, or if there are other barriers that might prevent us from implementing the standard PCIT. So either way, we should have a well-articulated reason and a good theoretical basis. And in general, changes include modifications to the CDI phase, for example, modifying the competency criteria for reflections if a child is lacking verbal skills, for example, or a modification to PDI skills, such as a modified timeout procedure, or an addition of a new model, for example, psychoeducation on anxiety, or the change in delivery of therapy. So PCIT has successfully been adapted to other populations, such as older children, toddlers, children on the autism spectrum, children who have experienced maltreatment or trauma, cognitive impairments, deaf and hard of hearing, callous on emotional traits, anxiety, which we'll be focusing a lot later today, and so on. And not only that, PCIT has also been translated and applied to various cultural backgrounds within and outside of the United States. So next, I'm going to pass it on to Dr. Toledano to discuss PCIT adaptations for anxiety.
Thank you. So now that we've talked about PCIT as a well-established intervention for childhood disruptive behaviors, we're going to shift and talk about why and how the same skills can be applied very effectively as interventions for childhood anxiety disorders. And then we'll get to how some unique skills are added to PCIT to specifically target anxiety. So first, some background on parenting interventions. So behavioral parent training, of course, is an umbrella term for interventions that influence parent behavior, where the expected outcome is an improvement in the child's behavior. And the connection between parenting behaviors and childhood disruptive behaviors has been fairly straightforward. And parent training has been seen as the optimal approach for addressing these disruptive behaviors, according to one review going back to about the 1960s or the 1970s. On the other hand, there's been less agreement about the ideal role of parents in anxiety treatment for kids, and it's been much more common to implement anxiety treatment in a one-on-one setting. So the same review I've cited here indicated parenting interventions for anxiety didn't start popping up very widely until about the 1990s. And surprisingly, when there have been meta-analyses comparing anxiety treatments that involve parents and those that don't, the outcomes actually haven't been very supportive of incorporating parents. So, of course, folks who work with kids are not willing to give up on including parents in treatment just based on those data alone. So a few groups of experts have argued maybe we were comparing outcomes across too many different types of interventions, which led to looking more closely at how parent involvement was defined across studies. So was it just including parents for a few minutes at the beginning or at the end of each session? Or was it a side-by-side session with the parent and the child, or any other variety of models? So given the wide variability in what has been considered a parenting intervention for anxiety, there's been an effort to identify exactly what components should be included in order to help guide interventions and then see if we're able to detect a stronger impact of parent involvement. On the parent side, some of the factors that are thought to be important in maintaining anxiety are over-involvement or over-control, such as parents stepping in and making a lot of decisions for their children. Reinforcement of avoidance refers to efforts to protect the child from difficult or anxiety-provoking situations. So you can stay home today from school because you're too anxious to go. And that falls under the broader category of family accommodation, where parents go to great lengths to prevent their kids from feeling distress. Another factor is when parents model their own anxious behavior, like avoidance or catastrophic thinking, sharing other kinds of maladaptive cognitions about how dangerous things are, for example. And lastly, some studies have found an association between childhood anxiety and very negative or critical interactions with parents, with the idea being that criticism instills a belief that the child is not very competent or capable. So each of these parental factors leads to a related intervention thought to be effective, including teaching parents to grant more autonomy to their children, enabling parents to tolerate their children's distress so they're not as likely to accommodate anxiety, teaching parents contingency management, which is also a way of reducing reinforcement for anxious or avoidant behavior, and challenging parents' anxious beliefs, including their own assumptions about what their kids are capable of. And for some parents, it may be relevant to increase warmth and positive feedback to help kids build a stronger sense of self-efficacy. So along with what I just talked about with each of those components, here's an interesting visual model that attempts to integrate some of the components we just talked about, linking specific parenting behaviors with recommended interventions. Does the parent demonstrate their own anxiety? If yes, we provide parental anxiety management. Does the parent engage in behaviors of over-control, rejection, modeling anxiety, or demonstrating negative beliefs of their children's capabilities? If yes, then it's indicated to offer parent training, teach parents to model coping, teach them how to use contingency management, and offer cognitive restructuring for the parent. And last, are there parent-child conflicts? If yes, offer skills in collaborative problem solving and enhanced communication. And this is one more attempt to narrow down the scope of parenting interventions for anxiety. So these authors identified two components of parenting interventions that seem likely to have an effect on child anxiety symptoms. So the first is transfer of control, which refers to teaching parents the skills that therapists use rather than treating parents as co-clients along with their children. And so the rationale is that parents will be able to extend the gains from treatment by coaching their kids for generalization at home and in other settings. The second component identified by this group was contingency management. So though contingency management is a really familiar concept for treating disruptive behaviors, one change we want to make when treating kids with anxiety is that we're teaching parents to take less control of situations instead of, with kids who have disruptive behaviors, needing to take more control or set more limits on behavior. So here we're really focusing on encouraging more autonomy on the part of kids. That might mean rather than reinforcing polite, appropriate behavior like we would for disruptive behavior disorders, we're setting up contingencies for reinforcement of brave or independent behavior. And at the same time, we use active ignoring with anxious behavior and then incorporate some limit setting to prevent excessive avoidance. So after identifying these components, these authors conducted another meta-analysis looking at the same question of whether parent involvement actually enhances anxiety treatment for kids, since we hadn't been able to demonstrate that before. So this time they made a separate category of parenting interventions that specifically included or focused on transfer of control and contingency management as components. So unfortunately, the first research question, the authors still replicated earlier findings that initial outcomes weren't much better when parents were involved, even when we pulled apart studies that incorporated these components of treatment. However, a significant difference did emerge at 1 year follow-up. So when the symptoms actually continued to improve, when parents were involved and used transfer of control and contingency management. So we are starting to see that at least one benefit of including parents in these interventions for anxiety is, in fact, the generalization and the longer-term maintenance of gains. And in addition, it's promising that we do start to see an impact of parenting interventions by taking a more focused approach to defining the most effective intervention components, because I think most of us who do work with kids intuitively know and believe that involving parents is very important. All right, so this leads back to the rationale for applying PCIT to child anxiety disorders. So when we look at the various targets that have been proposed as important in parenting interventions for anxiety, we can see that a number of them are already addressed through standard PCIT. PCIT is absolutely a transfer of control model, giving the tools of therapy to the parent. It does teach contingency management. It does promote child autonomy and decision making. And in fact, that's a major focus of the child-directed interaction phase. And it increases warmth and teaches parents how to send messages of approval to their kids. And in addition, the PCIT adaptations for anxiety that we'll discuss in just a bit have also included the unique components of reducing parental modeling of anxious behavior and incorporating exposure, which Dr. Yadegar will talk about next.
Exposures are the gold standard treatment for anxiety, and it's rooted in the negative reinforcement cycle of anxiety and avoidance. I realize this slide actually has animation. So Dr. Ton, if you can please, thank you very much, appreciate it. Anxiety often starts with a worry. For example, for a separation anxiety case, it may be a thought of something bad will happen to mom if she leaves or to me. Mom may get into a car accident if she drives to work. And then that oftentimes understandably creates a feeling of anxiety. Which then when we're anxious, we want to avoid that anxious feeling in the situation, so we avoid. So the child may cling to mom, asking, please don't leave me, please don't go to work, do I have to go to school? And then if we do avoid, so if mom stays home from work or the child doesn't go to school, then in that moment, anxiety will decrease. However, that decrease in anxiety is only temporary. And then we find that the cycle starts again. So the next day, the child has that thought, oh my gosh, will something happen to mom if she goes to work? And we get stuck in this cycle. So through exposure therapy, we break this cycle where instead of avoiding, we have the child and family participate in exposures. In simple terms, exposure means facing our fears. So for example, that may be slowly separating and practicing separating from mom for extended periods of time or for more and more difficult situations. Next slide, please. Thank you. There's two different theories and mechanisms of exposure. One is habituation by FOA, and that tells us that in an exposure, anxiety is going to increase, right? When a child is faced in a situation of separating from mom, that for a separation anxiety case, that would be anxiety provoking. When anxiety increases, there's an urge, as we know, to avoid. However, if the child avoids, then they miss out on the second half where they learn over time that anxiety declines on its own naturally if the child continues the exposure. So this bell curve is habituation. Between each exposure, there's also a habituation as well. So if the child repeats this exposure over and over again, then we see that the anxiety decreases at a faster rate, and the peaks are also lower and lower as well each time. Next slide, please. Thank you. Exposures activate the fear structure. FOA refers to a fear structure as a cognitive representation of the feared object or situation that comes with memories of that fear in that situation. Through habituation, this learned conditioned response of the threat association is unlearned by decreasing the fear over time. Next slide, please. More recent research has pointed to another theory, another mechanism called inhibitory learning by Krask and colleagues. So instead of unlearning, new learning takes place. So the threatening association is there's, in addition to that, there's new non-threatening association. So for example, that could be that the child learns, oh, mom didn't get into a car accident on the way to work, or it was anxiety provoking, but I was actually braver than I thought and I could do this. So those are new learning experiences. And while habituation still happens, meaning that anxiety decreases, it's really the new learning that is the mechanism for exposure. So the child either learns something new or is able to tolerate the distress. Next slide, please. We do an exposure in a hierarchical stepwise fashion. So before we start exposures, we create what we call a fear hierarchy or a bravery ladder, where we ask the child and the family to rate how difficult each of the exposures are. So there's a fear thermometer here. The fear thermometer is from 0 to 10, where 0 is very easy. The child is calm or happy. 10 is the scariest thing in the world. And around a 5 is where, yes, I'm anxious, but I could do this. So we see here that using the bathroom without mom waiting outside for a separation anxiety case is a little anxiety provoking, but not too much. It's at a 3. The scariest thing at a 10 is for this child to go to a sleepover. And then there's interim steps in between. We see some of these could be done in a session. For example, mom waiting in the waiting room during a session is also at a 3. And some of them are at home, for example, sleeping independently in their room. Next slide, please. There's 2 different treatment adaptations for PCIT for anxiety disorders that has shown positive evidence base. The first is PCIT for separation anxiety for 4 to 8-year-olds. The second is the coaching approach behavior and leading by modeling, or CALM protocol. This is for 3 to 8-year-old children and can not only be used for separation anxiety, but also all anxiety disorders as well. Next slide, please. Starting with the PCIT for separation anxiety, there's 3 different phases or modules. The first is CDI. This is what we already went over, which is the special time and the PID skills. Each of these phases starts with a teach session, which means that it's a parent-only session where the parents learn the skill, like a didactic session. So they learn in CDI teach the PID do skills and the don't skills, CDI do and don't skills. Each teach session is followed by the coaching session. Coaching session is the ear in the bud through either a one-way mirror or through the screen if it's over telehealth. Or it could be live in the room as well. Follow after CDI, the second phase is BDI, which stands for Bravery Directed Interaction. This is where the exposures start. For this program, PCIT for separation anxiety, the exposures are assigned as homework to do before the next session. The third phase is PDI. This is what we've already went over, the traditional PCIT. However, compared to the traditional PCIT, exposures continue during this PDI phase. There's also an additional adjustment where we don't use the timeout procedure for separation anxiety situations. Next slide, please. A little bit more about the BDI phase. That phase includes psychoeducation about anxiety, including the negative reinforcement cycle of anxiety and avoidance, which we already went over together. The CBT triangle, this is the link and association between thoughts, feelings, and behaviors. CDI during separation situations, so implementing and embedding those PID skills and the CDI don't skills within separation situations, creating the bravery ladder together, so the hierarchy that we went over, a reward system to further reinforce exposures, which we'll also talk about later as well. And then, as I mentioned, exposures are given as homework in between sessions. The parenting skills here really focus on decreasing parental accommodation. Accommodation is a way that anxiety is enabled over time by not encouraging avoidance and instead really reinforcing the approach of the separation exposures. Next slide, please. Okay, the CALM program, as I mentioned, is for all anxiety disorders, not just separation anxiety. It could also be used for GAD, social anxiety, specific phobias. Instead of exposures being assigned as homework, in addition to that, parents also receive live coaching. So this is the ear in the bud again, in guiding the child through exposures. This program has 2 phases. The first is CDI. During CDI, an exposure hierarchy is created, and we start with low-level exposures. So those initial, when we saw in the hierarchy, those ones that were rated like a 3 or a 4, those could be started here, where parents are coached through the ear and the bud with just the CDI skills here at this point. And then the next phase is the dad skill. Again, we start with a dad's teach, where parents learn the skills, and dads is a more way of directly guiding kids through the exposures when the CDI skills are not enough. And I'll go over each of those steps as well later. Followed by dad's coach sessions, which continues to have in-session exposure sessions. So here, exposures are practiced in the session and also for homework outside of the session. All right, and I'll hand it back.
All right, so here we'll talk about how components of these interventions, both standard PCIT and the adaptations of PCIT for anxiety, can be applied and integrated across treatment settings. So I'll start by talking about the specific skills of child-directed interaction and how these skills can be applied to anxiety treatment. And just to recap, CDI is a specific set of skills we teach parents to use with their children, both to improve the parent-child relationship, things like increasing warmth, promoting self-efficacy in kids, and to elicit desired behaviors, where we set the stage for contingency management by starting to reduce reinforcement for undesired behaviors. So in PCIT, the practice and coaching of CDI is what makes up the majority of session time during the early phase of treatment. And CDI is also assigned as a daily practice for parents and kids called special time. In fact, it's the daily practice of special time at home that's considered the mechanism of change in the parent-child relationship, whereas the in-clinic sessions are more about fine-tuning parents' use of the CDI skills. And third, CDI skills are intended to be generalized across settings and used throughout the day. And along with this generalization, therapists are modeling using the same skills with kids throughout sessions, even starting with our casual conversations in the hallway, walking to and from the session. So the takeaway here is that the skills themselves are pretty portable. While we wouldn't claim that we are practicing PCIT without completing the structured clinical settings, the skills are so impactful that we believe that they can and should be integrated into other treatment modalities when working with kids, both in how therapists are interacting with young patients and how we explicitly teach and coach parents to interact. And it's also important to mention that CDI is practiced pretty much as is across most of the PCIT adaptations. So we might use the skills to elicit different target behaviors, and we call that tailoring the intervention when working with kids with anxiety, but the skills themselves are practiced very much in the same way, so this part is not necessarily adapted. Here again are the specific CDI skills which Dr. Tan described earlier. I won't go into too much detail. So the PRIDE skills, again, are what we want parents to do more of in response to desired behaviors: labeled praise, reflection, imitation, behavior description, and enjoyment. And the other skills are referred to as the don't skills. So while we're using all the PRIDE skills, the mission in a child-directed interaction is to eliminate any questions, commands, or what we call negative talk. And in the next few slides, I'll provide examples of each PRIDE skill as it might be applied in a traditional PCIT setting, and then as it might be applied in the treatment of anxiety by either a therapist or a parent. And actually, the the typical PCIT examples are pulled directly from the coding manuals, so where we learn very standard examples of each of these PRIDE skills. So here's the typical PCIT example for a labeled praise. I might say, I like how you're sitting quietly. And we can infer this might be a really appropriate kind of praise for a child who has trouble staying seated and using an indoor voice. If we're treating anxiety, we use the same type of sentence structure, but we choose different targets for the praise. For a child with social anxiety or selective mutism, we might actually praise, I like how you're using a loud speaking voice. What about for a child with specific phobia or OCD with a fear of contamination? So great job opening the door with your hand if that's something you normally wouldn't do. And then conversely, in these cases, I'd like to point out where we would not use the PRIDE skills. So this is where the differential attention comes in, and we're pulling back our attention and not providing this kind of labeled praise. So what might be typical good behaviors for other kids, like being soft-spoken, well-mannered, washing their hands, those are things we might not want to praise because we don't want to reinforce possible symptoms of anxiety. So reflection, a typical PCIT example might be when we're playing with a building toy. So the child says, this piece doesn't fit. The parent responds, it doesn't fit. Applied to social anxiety or selective mutism, reflection is actually considered a really powerful tool. And the advice is to reflect just about anything if a child is known for not saying a whole lot. So if the child says, I want pizza, the adult says, you want pizza. It sends the message, anytime you're expressing your needs verbally, I'm going to let you know I heard you, and I'm actually really happy that you shared your needs. Doesn't matter if we're actually having pizza for dinner, but it's better to first reinforce that you spoke, and then I can respond with the answer to your request. Now let's try applying reflection to a specific fear. So what I would do here is be on the lookout for any time the child makes a statement of self-efficacy. I can open the door by myself. I would reflect that. You can open the door by yourself. So each reflection, even though it doesn't include any specific words of praise or approval, still sends the message, I like what you're saying. And because reflecting actually serves as social reinforcement, we're equally careful with what not to reflect. So for kids with selective mutism, the first thing is not to reflect an unverbalized thought, which would really just be mind reading or kind of a rescue. So the idea is to wait for any kind of verbalization, even if it's just a whisper, and reinforce that. And we also don't want to reflect specific fears, like this is dirty, I'm going to get sick, or the dog is going to bite me. Those are times I would just stand by quietly and wait for a more brave verbalization to come up, and I would reflect that. Imitation is one of the nonverbal PRIDE skills. So it requires either mimicking what the child is doing to some extent, or maybe just using similar materials. A typical PCIT example, which would be occurring in a play situation, would be when a child picks up a car and flies it through the air, pretending it's an airplane. The adult picks up the car, flies it through the air, pretends it's an airplane. It's a great way, just like all the PRIDE skills, to express approval of the activity and to build joy in doing something together. But let's take imitation as a general principle that could be applied for someone going through anxiety treatment. So we can think of imitation as reverse modeling. My child models something really brave by talking with a peer on the playground. So if I'm a parent standing out there with them, what better way to express my approval and admiration than to turn to the adult next to me and start my own conversation? So that may sound like a simple example, but often when we suggest exposures for kids, parents, if we've not done a lot of coaching, and if we haven't been using that transfer of control model where we're teaching them the importance of these skills and how to use and apply these skills, parents might make an offhand comment like, well, no way I would do that, kind of standing back and watching their child engage. So it's critically important for parents to be willing to imitate. Another really relevant example of imitation is during exposures. So say as part of an exposure, the child is touching the bottom of their shoe. It's incredibly powerful as a therapist or as the parent to join in and touch the bottom of your own shoe, or maybe another dirty shoe you can find. So it sends a message of not only approval, but I'm in this with you. And when a child is doing something that's very brave and very difficult, it's also just important to show that you're completely dialed in and paying attention because you understand that this is a big deal. As you can guess, under this exposure model, we would not use imitation with any of the safety behaviors like hand washing or hand sanitizing. If the child does give into a compulsion like that, at least they won't be getting the added reinforcement of seeing a trusted adult do the same thing. Behavior descriptions are statements of what the child is doing. So our typical example here, playing with a farm set, for example, is you're feeding the cow. If I'm working with a child on social anxiety, I might say, you walk to the classroom all by yourself. Just like reflection, behavior description is a verbal skill that reinforces behavior just by calling attention to the behavior, even though we're not going the extra step of explicitly praising the behavior, saying great job, or I like that you. So simply, you walked all by yourself. And I really see the value of behavior description working with teens or older kids who sometimes have a really paradoxical reaction to praise. So a subtler approach of just naming the behavior sometimes is received even better than praise. And when targeting a specific fear, again, going with our contamination example, we could describe any behavior that challenges the fear, like you ate that chicken that fell on the floor. And of course, we would not describe any behavior that's aligned with the anxiety or happens in response to the anxiety. So throwing away the chicken. And the last pride skill, and one that's kind of underlying all the others, is enjoyment. So in typical or standard PCIT, often we're experiencing that a parent-child relationship has been strained, and it's much more important to go overboard in conveying warmth and genuine enjoyment in all of these interactions. So we're coaching parents to smile, practice an authentic tone of voice, and use some physical affection. All of these examples can also be applied to anxiety treatment, and we would just make sure to practice added warmth, enjoyment, and enthusiasm anytime the child is engaging in treatment and approaching whatever it is they fear. Of course, it's also important not to go over the top with our enjoyment because we don't want it to seem like we're getting joy out of something that the child perceives as really difficult. But in expressing a positive attitude toward treatment ourselves, we're sending a message, hey, I'm kind of in it with you and I'm really proud of you. And then, of course, it's important to limit our own expressions of fear, disgust, reluctance, any statements like, I can't wait until this exposure is over, and instead focus on the positive emotions that come from conquering a fear. Now let's talk about the don't skills of CDI, which are the things that we teach adults not to say while they're practicing all the pride skills. So during those times, we instruct parents not to give any commands or direct behavior in any way, not to ask questions, and not to give criticism or make any kind of statement of what a child should not do. The don't skills are really aligned with some of the targets of parenting interventions for anxiety in that they ensure that we're not taking over control of a situation when it might be better to let the child take the lead, and they ensure we're not instilling feelings of guilt or shame for behavior. So rather than criticizing undesired behavior, what leads to the behavior change is the combination of using all those specific verbalizations like labeled praise, behavior description, and reflection to reinforce behaviors, and then not using any of those verbalizations or any other attention which could reinforce the undesired behavior. So when I say desired and undesired behavior, it's the same with anxious behavior versus brave behavior. And for a wide variety of behaviors, it's that simple turning on and off of attention that's highly effective in bringing about behavior change. Of course, asking questions and telling a child what they should do can't always be avoided. And not every interaction throughout the day, certainly not every therapy session is a child-directed interaction. But the thing to keep in mind is that kids' lives are often so managed by adults, we can really make a big impact by simply reducing questions and commands to when we really need them. So think to yourself, is this a situation where I need to use a question? For instance, as a therapist, you may want to ask a patient, can you add more detail to that worry script? But think about how another tool like behavior description, wow, you added a lot of detail to this part of your worry script, would have the same effect. It would still encourage adding more detail. It calls attention to that behavior, and that's likely to bring about more of that without asking a question or giving a command. And then negative talk can usually be avoided. So applied to anxiety, it's important not to criticize or convey disappointment in the anxious behavior. And next, Dr. Yadegar will talk more about some of the other skills of PCIT beyond CDI, including a specific adaptation for anxiety that's not part of standard PCIT.
So we talked about exposure therapy, and now we want to talk about how to integrate exposures into PCIT following CDI. I mentioned that the CALM protocol uses the DADS acronym. Here we want to focus more on the exposure phase of treatment and how to implement exposures into PCIT following CDI. Just to review, exposures are facing our fears and practicing being brave. So in the CALM protocol, the DADS phase focuses on parents being more directive with guiding their child through exposures. And then the therapist is coaching the parent through that process. DADS is an acronym. The first D is for the parent to describe at least 3 statements about the feared situation. If the child approaches the exposure at that point, then we praise automatically with a labeled praise. If not, then the parent models by approaching the feared situation, the exposure themselves. After 5 seconds, if the child still does not approach, then the parent can go on with a direct command. Each of these steps is integrated within CDI. So when a child approaches, we label praise right away. If not, then we either move on to the next step, or lastly, after the direct command, then selectively attend. So we ignore the avoidance. Next slide, please. We'll go through an example. Let's say we have a kiddo who is afraid of dogs. A describe can start with 3 very neutral statements. So for example, this dog is brown and white. It has spots around its nose. She's looking up at me. You notice here that the statements were very fact-based. They weren't overly reassuring. Like, for example, this dog is so small, there's no way that it can scare you. Very neutral. Next slide, please. Okay. If the child still doesn't approach, then the parent approaches themselves by modeling. They could say something like, I'm going to sit next to the dog, or I'm going to pet the dog. We wait again at least 5 seconds. If the child approaches, we want to praise right away. Thank you for listening. Thank you for sitting next to the dog. I'm so proud of you for being so brave. Next slide, please. And if the child still doesn't approach, we can follow with a direct command. Just to review what direct commands are, they're declarative statements that are said positively and tells the child exactly what we want them to do. So for example, please come here and sit next to me and the dog, or please come here and pet the dog. We want to try to avoid indirect commands. Indirect commands make it unclear what we want the child to do. So for example, let's go pet the dog together. That's an indirect command. It's unclear. Or sometimes it could also be like a question, like, why don't you pet the dog? It has that tip up there. Instead, we want to be very direct. If the child doesn't follow through with the direct command and then approach the exposure, then the parent can provide a brief statement about remaining in the exposure themselves. For example, I'm going to keep petting the dog, and the parent stays in the exposure to model. Next slide, please. If the child approaches at that point or at any point, we want to label praise. I'm really proud of you for being brave and petting the dog, or providing a behavioral descriptions, like you're stepping closer to the dog. So any kind of approach behaviors to the exposure, we want to reinforce and increase. So they're either followed with a labeled praise or a behavioral description or a reflection. And then any behaviors that are avoidance behaviors that we ignore because we don't want to increase them. Next slide, please. Here's another example. This is an example of a socially anxious child ordering ice cream. So we start again with a describe 2 to 3 statements. We are inside the ice cream store. I see a lot of delicious flavors. No one is waiting at the counter, so we can order right away. So if the child orders, we label praise right away. If not, then the parent goes ahead and approaches the exposure themselves to model. I'm going to order my ice cream. Hi, I would like a small chocolate ice cream scoop on a cone. Then if the child orders, again, labeled praise. If not, after 5 seconds, then the parent can give a direct command. Please tell the person behind the counter what kind of ice cream you like. And then if the child still does not order, then we move into selective attention. Maybe there is a small behavior that we can praise, like, I like that you're looking at her, or great job getting a little closer to the counter. So any small behaviors that we see that are positive, we want to jump on them and reinforce them. If the child still doesn't order, you can loop back to any of these previous dad's steps as well. CDI Skills is incorporated and embedded throughout. So if the child approaches, we label praise, and then we can also use other CDI skills like describes and reflections. All right, next slide, please. We previously talked about how exposures are practiced not just in session, but also outside of session. So we ask parents to track how those exposures go for both data and also so that it encourages continuous practice of the exposures. So for example, in this tracker, we have parents include what the exposure is and then each of the dad steps, and also the parents observed fear thermometer rating. So that 0 to 10 scale of how anxious they observe their child to be. Next slide, please. All right, I'll pass it back to Dr. Toledano.
This is actually my section for reward system and contingency plan. So at times, we may also fold in the implementation of reward system and contingency planning within traditional PCIT, as well as PCIT adaptations for anxiety with exposure therapy. And this is when, you know, the label praise, the verbal encouragement, the selective attention are not enough. So the goals of implementing a reward system is to establish a formal and consistent system that make certain rewards contingent upon the child's expected behaviors. And in the case of anxiety treatment, it would be behaviors where the child is approaching an anxiety-provoking situation, they're resisting avoidance, or when they're completing their exposure homework. And this also helps increase parental attention as well as positive reinforcement for the specific expected behaviors. And it helps decrease just the unpredictability of parental responses as well. As a lot of times when parents get frustrated, they might say certain things that, you know, it's hard for them to follow through or make consequences that are hard for them to follow through. So a specific and consistent system would help decrease the unpredictability and increase the consistency. And overall, a good system can also help a child set them up for success because they know what to expect and they know that when they're engaging in certain behavior, certain rewards and consequences are to follow. So here are some tips to help parents set up a reward system. So first, we want to be clear. We want to clearly define what the expected behaviors look like, as well as what the expected rewards are for each of the behavior. 2, we want to be open. We want to be open to the child's involvement in identifying the variety of rewards that they find motivating and that are realistic and attainable. We want parents to think of rewards broadly. It can be treats, specific items, points, stars to cash in for things, fun activities, extra screen time, special time with parents, getting out of chores, and so on. And the third is be consistent and immediate. We want parents to reward as soon as the expected behaviors occur. And it also helps when there's consistency between parents or caregivers. And this again increases the predictability and the likelihood that the frequency of the expected behaviors will increase over time. Fourth is be positive. If a child fails to demonstrate expected behaviors, we want parents to gently remind them of future opportunities rather than criticizing or highlighting their failures. And next is be flexible. We want parents to be able to adjust reward systems over time if it appears to be too easy or too hard, or when previously established rewards are no longer of interest or motivating. And lastly, we encourage parents to be creative. We want to make this fun to help the kids sustain their attention and interest with the reward system. And sometimes as therapists, when we introduce reward system, we may get some concerned response from parents. So here are some common parental responses as well as some troubleshooting solutions. So sometimes parents might say that, it feels like bribery, like I'm bribing my kid to do something. So a solution would be to really correct the misunderstanding of the concept of bribery. Because if we think of bribery as an incentive for committing something that's illegal, which it is not the case of what we're trying to do here. So rewards can be a helpful tool to help improve self-regulation and improve the motivational deficit. It helps the child learn important life skills that when we put time and effort into things, we get positive outcomes. Like I get paid when I go to work. I get to learn new knowledge when I listen in class. I feel good or smell better when I shower, for example. Another common parental response would be, it is too time consuming. And, here we encourage therapists to acknowledge that, yes, it might take a little more time initially to help set up the consistent and formal system. However, it will reduce time in the long run. And sometimes parents might also say that, hey, it's not fair to my other child if I'm doing a reward system with this child and not the other. And this is where we would encourage therapists to discuss with parents the feasibility of implementing similar reward systems for other children in the family or establishing some sort of a house-based rule. And lastly, parents tend to say, how long do we need to continue to implement this? And here's where we want to reinforce the importance of consistency and discuss the plan for gradually phasing the reward system out. We're seeing progress with behaviors over time. And here are some examples of reward systems. So simple token economies where we might reward bravery behaviors with things like stars, stickers, smiley faces, face points, and so on. And these tokens can be cashed in for specific rewards. And for older children who might have outgrown reward charts, we might use things like behavioral contracts. And lastly, for anxious children who tend to seek a lot of reassurance, parents can set up allowance limit to help the child resist the urges to reassurance seek. For example, they might get 5 tickets a day where they have 5 opportunities to reassurance seek. And the tickets are taken away if the child seeks reassurance. And over time, those tickets can be accumulated to be cashed in for specific rewards. And this can help the child teach them self-control as well. So they can say, do I really need that reassurance, or can I, save this for something else? Next, I'll pass it back to Dr. Yadegar for our case discussion.
Okay, next slide, please. So here we have a case, a 6-year-old called Lily, who is a Japanese American 2nd-generation female, lives with her mom, dad, and maternal grandmother. Parents are coming in primarily for separation anxiety. Lily has a hard time being in a room by herself and using the restroom on her own. She sleeps with her parents. And when parents try to encourage her to go to the bathroom or sleep in her own bed, she often tantrums, like yelling or throwing her stuffed animals, until parents accommodate by co-sleeping with her or accompanying her to the bathroom. She also has a hard time listening to her parents generally. And parents oftentimes need to repeat themselves for Lily to perform simple grooming tasks like brushing her teeth. She has no difficulty following directions or listening at school. So here we see that a separation anxiety primary case, but there's also some behavioral concerns too, that when Lily gets anxious about separating and parents try to set a limit and encourage her, that she has tantrum behaviors. We also know that she has the ability to listen and follow directions at school. So that's a sign that the environment is likely to play a major role. Some cultural factors to think about here. One is that the ethnicity and the culture of the family. For separation anxiety, I oftentimes ask the parents, is this a goal or is this creating problems for you to co-sleep together? Is co-sleeping common in your culture, or how did you grow up? In Asian families, actually, is co-sleeping may actually be common. Another is that we see that maternal grandmother is at home as well. So that may be something to think about, of how involved is this grandmother, and does Lily have a hard time separating from grandmother? If so, it may be something to think about, to also coach the grandmother as well in the same skills as she'll be involved in the exposures. Next slide, please. I'm realizing that we're low on time, so I'm gonna fast pace a little bit. So the treatment may consist of what we talked about before, CDI, and then the DADs, where exposures get into more difficult exposures. As always, we start each of those phases with a teach session where parents learn the skills on their own. Next slide, please. Thank you. So here is the DPICS coding sheet, where I would go ahead and code the parent during CDI in the first 5 minutes, where I'm watching and observing quietly. So you see over time, there's a trend of increasing skills, where we want to get to the point of 10 labeled praises, 10 reflections, and 10 describes. After those 5 minutes, I briefly give parents feedback. So for example, let's say in session 3, I would tell the parents something like, you had 7 labeled praises, wonderful job with that. We had 6 reflections, and we had 4 describes. Let's focus on describes today and see how many we can do in the next minute. Next slide, please. We went over our exposure hierarchy. For each child, we would individualize and tailor the exposure hierarchy to the child. So Lily's looked something like this, starting with the parent leaving the therapy room for just a few minutes during CDI, while child continues to play with the therapist, all the way up to sleeping alone in her room. Next slide, please. We also talked about outcome monitoring briefly in the beginning. The ECB is the behavioral outcome measure. So we see over time that huge drop in the blue line shows a decrease in the intensity of behavioral problems just during CDI alone. Next slide, please. The SCARED is an anxiety measure. It's standardized for kids 8 and up, but unfortunately there's not too many, or there's actually none that I'm aware of reliable and valid anxiety measures for kids that are younger than 8. So I oftentimes continue to use the SCARED. Here again, we see that there's a huge drop in anxiety just in CDI alone. And that's one of my favorite parts about PCIT, is that CDI and those positive reinforcement skills for parents alone shows great and rapid improvements. And providing this, I oftentimes score this each session and provide this feedback to parents. So parents are seeing every week the improvements that they're making, which is really validating for them. Next slide, please. If Lily had more severe and debilitating separation anxiety and she needed a higher level of care, such as what we provide at Rogers, what would that look like? So in addition to Lily having a hard time sleeping and using the bathroom alone, these more severe cases for Lily, it may look like she's not able to attend school. And if she's not able to attend school, she's not learning, she's not seeing her friends. So it also impacts her social functioning as well. And parents at this point are oftentimes considering homeschooling. They haven't already. Next slide, please. In a PHP or IOP setting, treatment's more intensive, so it allows for more exposure time in the clinic with the clinician being there to support the family. There's also more times for like separation exposures. So that may start with the parent being in the room next door, the parent going to the bathroom, the parent waiting in the waiting room, the parent going to another floor in the building, out in the car. And then if it's live coaching is in the room coaching is not possible through the one-way window, it can also be in the same room as well. At Rogers, in addition to individual time, there's also groups as well for children to learn coping skills alongside their peers, and then a separate weekly parent group as well. At this level of care, children are so severe that they oftentimes need the support of medication to help them be able to start the exposures. So we have psychiatrists within each of our treatment teams. Next slide, please. But the core components are really the same of the behavioral skills and outcome monitoring. All right, we're done. Thank you for bearing with me.
Thank you so much. We'll try to get to a few of these questions. If you do have a question, please use the Q&A button, not the chat feature on the Zoom taskbar. We will try to answer as many as we can in the time we have left. If we don't get your question, please send me an email message afterwards and I'll be sure to follow up with you. Okay, the first question that we have is, given that original PCIT was designed for kids 2 to 7, and most PCIT providers have a 10-year-old ceiling on who they usually see, what kinds of adaptations are there necessary when working with older kids or young adolescents and their parents? And many people ask, can we use this with teens?
Sure. So I'll take a stab at that. So I did mention earlier that, for instance, people have noticed older kids and teens don't have the same positive response to labeled praise all the time. So there actually have been adaptations proposed and published on for older kids that involve fewer verbalizations from the parent overall to meet kind of those confidence criteria, and also just different sort of nuances of how we praise and how we, you know, maybe the enjoyment or the enthusiasm is a little bit dialed down, or more matching reflections, for example, are often more complex instead of just stating back or parroting back what someone has said. But in terms of applying these skills across the age range, in general, I think that, you know, some of these skills are applicable to anyone. So I find myself using these skills in all sorts of therapy sessions with people of all ages. I find myself using CDI skills with peers in the clinic. So I think, you know, there are both adaptations that can be made for older children when we're doing PCIT, but kind of one of our hopes is that some of the components can be used anywhere.
Thank you. The next question is with respect to the DADS sequence you discussed. Has there been, in your experience, that children can show additional benefits, response, when other adults, like a therapist, a teacher, etc., are also working on the same routines with the child?
Absolutely. So especially when another adult is accommodating, or like, for example, living with the family, like with the case of Lily, then it's wonderful to have those others, whether that's other caretakers, grandparents, teachers, to be involved and updated of where a child is in their hierarchy and their exposures are working on. And if it's possible to teach that person some of the CDI and DAD skills themselves. So Lily's grandmother actually came in and had some coaching sessions and a teach session to learn those skills. There's also a teacher adaptation for PCIT called TCIT that teachers can learn as well if they would like to.
Okay. And then our final question, are there times or presentations where PCIT is not indicated?
So there are, and I think that there might be a difference in discussing that versus using these skills for anxiety. In traditional PCIT, there are instances where there might be current or ongoing child maltreatment where it's not indicated, but notably when that kind of parent behavior is over or has been addressed, PCIT can actually still be quite effective, and otherwise it's pretty broadly applicable.
Thank you so much. Okay, so that's all the time we have for questions today. But if I didn't get to your question, please feel free to send me an email to webinars@rogersbh.org. Many thanks to our presenters for taking time away from your clinical practice to share your valuable insights with us. Helping a patient on the road to recovery means collaboration among everyone involved in their treatment. With locations across the country, our treatment teams are ready to partner with you. And Rogers outreach representatives are happy to answer questions regarding our treatment services, as well as learn more about your practice. Before we conclude, I'd like to ask our presenters to share a few recommended resources on this topic with our participants.
Sure. So there's the PCIT International website that has a lot of really great resources. The SPACE program focuses specifically on decreasing parental accommodations, and that actually has a wider age range as well. For more traditional PCIT, there's some great resources, including videos in the West Virginia University PCIT lab, and the link is there as well.
Thank you. That about wraps it up, everyone. I just want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. About 30 minutes after the webinar ends, you will receive an email with a link to your personal dashboard on ce-go.com, where you are able to access PDFs of the PowerPoint presentation, slides, and handout complete with the list of references mentioned here today. Those of you who met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate for the event. If you do have any questions about this follow-up email, please contact support at ce-go.com. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Have a great day.